welcome. My name is Marissa Lozano. I'm the Director of Community Education at the Muscular Dystrophy Association, and I'm so glad to have you here with us today. This is part of our three-part series on gene therapy, we are focused on gene therapy and the advancements and considerations in gene therapy across all neuromuscular diseases. And we hope this series will provide the patient community with a great understanding of the topic and will empower you to make informed decisions about your care and the care of your loved one. With that, we are pleased to have interpreters on the line today joining us to make this available to patients and families in Spanish. I'm going to briefly turn it over to Pedro from Bruce Lingo to just share some instructions on how to join the audio.
Excellent. Thank you very much, Marisa. ¿Qué tal? Muy buenos días, tardes, dependiendo de dónde se encuentren. Mi nombre es Pedro Prendes y soy parte del equipo técnico de Boost Lingo Events. Y hoy les voy a explicar brevemente cómo pueden ustedes acceder a lo que es tanto a la Liga de la Interpretación, que en este momento podrán ustedes encontrar en el panel del chat. Si ustedes hacen clic allí, podrán acceder a este mismo panel de audio con el cual a ustedes les permitirá acceder a lo que es a la interpretación simultánea correspondiente que tendremos habilitado para esta sesión. Les invitamos también para poder tener una mejor experiencia con la herramienta de interpretación. En dado caso que ustedes estén sintonizando nuestra sesión en la plataforma de Webex, en la aplicación de escritorio, les sugerimos en donde se encuentra el icono para silenciar o activar el micrófono, donde aparece una flecha apuntando hacia abajo, les va a aparecer una opción que dice configuración de audio. Si hacen clic allí, van a poder reducir el volumen del audio original y asimismo podrán sintonizar de manera más óptima y con un mejor volumen en el panel de Boost Events dentro de un navegador aparte. Asimismo, también sugerimos el uso de su dispositivo de smartphone para poder escanear el código QR que también aparece en pantalla, para que también puedan ustedes sintonizar la interpretación correspondiente de esta sesión al español. Una vez que accedan a la panel de la interpretación, van a tener también habilitada la opción donde dice Languages y en donde dice la palabra Floor. Les invitamos a que hagan clic allí y se abrirá el panel con las diferentes opciones de idiomas que tendremos disponibles para la sesión. Les sugerimos seleccionar el canal de español para que puedan sintonizar la sesión totalmente al español. Asimismo, si llegan a ver un mensaje que dice Missing Audio, simplemente hagan clic en la opción de Missing Audio y seleccionen nuevamente el canal de español. Sin ir más lejos, voy a devolverle otra vez la palabra a Marisa Lozano, que es parte de nuestro equipo de hoy de MDA de la sesión de hoy. Thank you very much, Marisa. The floor is all yours. Thank you very much.
Thank you, Pedro. So we always like to start these webinars with our mission. For nearly 75 years, the Muscular Dystrophy Association has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. Our mission is to empower the people we serve to live longer, more independent lives. MDA delivers its mission through many different ways: research, access to care, advocacy, education, recreation, and engagement. Since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research. Specifically to this topic today, MDA has invested over $125 million in the development of gene therapy for neuromuscular diseases over the past 2 decades. With new gene therapy drug approvals in the pipeline, MDA is here to facilitate access and to provide support and education to the neuromuscular disease community. It's now my pleasure to introduce the speakers for our first presentation today. Dr. Michael Storey is Medication Use Strategist at Nationwide Children's, where he leads the onboarding and maintenance of high-touch therapies across the hospital. He's been involved in the clinical, operational, and financial execution of gene therapy for approximately 70 patients across multiple diseases. He has worked closely with the neuromuscular clinic since 2017. He coordinates Nationwide's Pharmacy and Therapeutics Committee and presents nationally to pharmacists regarding gene therapy and physician and industry groups regarding operational and financial aspects of therapy delivery. Prior to his current role, Dr. Storey managed inpatient pharmacy operations and clinical services for several areas around the hospital. He has a Doctor of Pharmacy from Ohio Northern University and a Master's of Science in Pharmacy Administration from the Ohio State University. And then Paul Melmeyer serves as the Executive Vice President of Public Policy and Advocacy here at the Muscular Dystrophy Association. In this role, Paul leads MDA's policy and advocacy initiatives pertaining to public health, therapeutic development, access to care, and disabilities. Prior to joining MDA, Paul spent over 6 years with the National Organization for Rare Disorders, or NORD. At NORD, Paul led the federal policy operations in developing and advocating for the enactment and implementation of pro-rare disease patient policy. Paul also holds a Master of Public Policy from the George Washington University. Thank you both for being here today, and I will now turn the time over to you.
All right, I'll go ahead and get started here. Thanks, Marissa, for the introduction and for the for the introduction and everything. I'm really happy to be here to talk to everyone about the gene therapy process and all the issues that we've encountered with insurance. And I think just to kind of give you a little bit of an overlay of how the presentation will go, I'm going to talk about specific issues that you as a family will encounter in trying to get a specific patient across the finish line to gene therapy. Paul's going to talk more about some of the policy situations that we have that he's trying to advocate for our patients with neuromuscular diseases in terms of creating access for insurance in that way. And so I'll get started here talking a little bit about obtaining insurance approval. And I think the pretext to all of this is we learn new things about insurance every time that we go through a new insurance company. So your insurance company may be different than another, even if they appear to be under the same national brand or something like that. And so there are certainly unique aspects of that. And I think a lot of the families who I've worked with would reflect on that, that they thought, oh, I knew another family who had this insurance company, but as it turns out, because of the way that their employer is structured or their specific state or something else, it ends up being a little bit different. And so, just kind of being aware of that, and as we move forward, that will evolve with time as insurers also change their own internal processes. So the first thing I want to talk about is just understanding your insurance. So there's these different categories, and I will say a lot of the screenshots that are in my presentation are from the MDA document about navigating insurance. And so if you're trying to take screenshots of any of my slides, you're welcome to do that. But there's a better document out there, and so the MDA has put out a document about this as well. So just know that, and I'll talk a little bit off of the slides. I'm not going to necessarily read everything that's on some of them because of some of those details. But there's some of the things that you, and I think Jessica just put in the chat, so appreciate that. So some of the things that we want to look at is just understanding what's your out-of-pocket going to be. Now, there are assistance programs from the drug manufacturers. There are other assistance programs out there that may be able to help with that, but just understanding what is my expense going to be. And so, obviously many of our families are accustomed to dealing with insurance for a whole variety of reasons, because when you have any chronic disease, you end up, using your insurance more than the average person. But this is going to be something where you're likely going to encounter that. Benefit exclusions. This has been the hardest part, I think, of gene therapy insurance issues, in that insurers can, especially from employer-sponsored plans, and I'll get more into this in a minute, can actually just say that gene therapy is excluded. And so there's different ways to attack that challenge. The medical policy. So all insurers will issue medical policies for lots of different medical care that's provided, including drugs. So if you want to, one of the things that you ought to do is understand what your medical policy looks like. Realizing that we just had a label expansion for Elevidys, we also know that these will be evolving over the next several months. So continuing to evaluate that and seeing how they change those policies is also important. Medical necessity. This is where this is actually sometimes defined in policy documents. In general, gene therapy for muscular dystrophies that are FDA approved are going to be considered medically necessary, but just kind of understanding that that is important. And then medical and prescription coverage. Yes, this is a drug, but this is almost certainly going to fall under your medical benefit. But there may, depending on how your treatment center handles it, it may go through a specialty pharmacy, which adds a whole other layer of confusion to all of this. But it's likely going to be billed through your medical benefit, not through your pharmacy benefit for gene therapy. And so that may be different than, for example, if you are on an exon skipping therapy, which could go through either your medical or your pharmacy benefit. It's just a different structure here. And so just kind of understanding how that works. One of the things that I will say that has helped many patients is getting a care advocate or a case manager from the insurance company. A lot of times when we hit snags in the insurance process, these people are able to help kind of navigate us through. And so I can think of a couple of patients in particular, where it wasn't that we were getting a denial. A lot of times it was that we weren't getting a response to something from the right area of the insurance company. And try as we might, as the hospital staff and as the family, trying to get through to the right area was really challenging. And so or they were telling us something that didn't quite make sense, and trying to make sense or get that in writing was something that we needed, and they are able to help with that. So I think just knowing this, you can do this up front, but I think that especially if you are hitting any serious delays, especially prior to actually getting something saying you're approved, this is going to be harder. Like, they're not going to be as helpful with some of the single case agreement stuff that I'll talk about later, but especially with getting an actual approval to be able to move forward, they'll be very helpful. And then I think working with your healthcare provider. Obviously for insurance authorizations, this information is usually submitted by the care center. And so they're going to be compiling this information and then submitting it to the insurer on your behalf. Most of this is information that you probably have access to through your patient portal in the electronic medical record, but also that the medical team has access to. And so there's all the necessary paperwork that you need to submit either to the insurance company. The prescription form is usually going to go to the drug company, but overall, just kind of compiling all this information. You'll probably sign the prescription form during your appointment. And then there's the understanding the logistics. I think talking to your team about that and setting expectations. What are the things that need to be done before? Is there certain screening that has to happen? You'll probably get some labs checked. There may be additional screening. I know for us, we're doing a lot of cardiac screening in advance of giving Elevidys, for example. And so I think and we'll probably do that for a lot of other gene therapies that may come in the future, for limb-girdle muscular dystrophy and things like that. There's likely going to be similar baseline screening. And so just understanding all of that, understanding where you sit where the hospital sits with insurance contracting. Over the long term, the goal for me as someone who works in this space in the hospital, for my contracting team, and probably also for the insurance companies, is to get these written into our long-term contracts with the insurer. This obviously reduces the amount of back and forth that we have to do. It also expedites access for patients. But that takes a lot of time. So for Zolgensma, that's been approved for now over 5 years, we have that written into our contracts for the vast majority of the major insurance companies in the United States. For Elevidys, we really only have that for a couple. And so and I would say that a lot of sites have that written in there for almost none. And so I'm just telling you like that overall, like understanding what that looks like for your site, and just asking the team, how long has it usually taken once we've gotten an approval to actually treat the patient? And unfortunately, sometimes this takes a couple days, and sometimes this takes a couple months, and it's sometimes hard to predict. So that's one of the things to think about. Product shipping, different drug manufacturers for gene therapy have different shipping timelines. It may take 2 weeks from the time that everything gets settled with insurance contracting to get the drug on site. And then the clinic obviously has to be able to schedule you for a clinic for the appointment to receive the infusion, and the hospital may or may not have capacity constraints on that. So just understanding that. And then the healthcare provider is also going to help you navigate appeals. Navigating appeals is definitely where there's a lot of unique elements for different insurance companies in different situations and why you have denials. So I'm going to talk about some of the different reasons for denials and tactics here in a few minutes. Connecting with the pharmaceutical company. Now, I will tell you, for most of these therapies, you don't have to connect with the pharmaceutical company, and so they may want to connect with you for a variety of reasons. You can decline that, and you can withdraw consent from that at any time. But what I will say is that there are certain things that they can provide. The main thing that I will talk to patients about for this is resources related to supporting families in terms of copay assistance for commercial insurance, as well as they have some travel support as well that may be helpful for some families. They have a lot of other things. I generally, as someone who works in a clinic, my position is that I want you to come to me when you have questions about the disease or the therapy or anything like that. And sometimes there can be some blurring of lines. So just, I think talk with your clinic about that. But overall, there are some benefits for families. But if you don't see a benefit that you're going to receive, you can withdraw your consent for them to reach out to you or to speak with you about this. So just up to you in that regard. Submitting documentation to different places. So submitting it to the insurance company is obviously important for getting the approval. You also have to submit information to the drug company in order to order the drug. Like I say, you can limit the consent for what exactly you are consenting to sharing and discussing with them, but you definitely we have to send that in on some limited basis anyway. And the one thing I will say is as you are submitting information to an insurance company, the first thing that one of the things you want to know before you submit that is, does your child meet the insurer's medical policy criteria or not? Because if they meet the criteria, I'm going to have a very different approach to how I pursue the authorization than if they don't. If they do meet the criteria, my goal is just to make it as easy as possible for the insurance company to say yes. And that's always my answer, but my approach is going to be different. So there's a couple of different ways that I do this. So there are two different tactics here. So the insurer may have a form like you see on the left, and that form will basically be their medical policy broken into different questions. And so this is one insurer, and I just kind of snipped it out of their policy. But basically, if my patient meets the criteria in that, I fill that out, I submit appropriate documentation to support those answers, and I expect it will get approval. If they don't have something like this, but they have a medical policy, I like to write a brief letter like you see on the right. And basically, I put the insurance company's criteria on one side and the patient on the other. I don't need to give them all the information about this was approved in this and in this study and all the information. I just need to talk about why what they've already agreed is medically necessary applies to this patient. And so I try to make that as simple as possible. And so I use a little table like this. If you don't meet the medical policy criteria, then you're going to go with a little bit of a different approach. I think the thing here is to ask the provider to write a detailed letter. You want to make short factual statements about the patient, and then provide the latest clinical data, especially as it's relevant to that patient. So if you're trying to get a patient who is non-ambulatory approved for a drug, don't submit all the information about how this helped patients walk, because that's probably not relevant to the patient that you're looking at. If you're trying to get a patient who is a teenager approved, you don't really want to just focus on data from young children. And so really trying to think about, what is it about this patient, especially why does their medical policy not cover this patient? And then addressing that head on, I think, is important. If they do not meet the medical policy, you should anticipate that you're going to get a denial in the first round, because the people who are reviewing that in the first round, all they're doing is they're just looking at it and saying, does the patient meet these criteria? If not, denied. They don't have the authority to overrule the medical policy or anything. It doesn't mean we don't put all the information out there up front and be proactive about it. But I always tell families, your child doesn't meet their medical policy, anticipate a denial. Where we win is we win on appeals in that situation. And so we'll put our best foot forward on the front end, but just understand that they don't have the authority to actually do it. So unless they make a mistake and approve it up front, they're not going to approve it on the front end. So you're going to get a determination then. So if you get an approval, great, but that's not the end of the journey. There's additional things that have to happen. Usually that'll get faxed or emailed to your provider. Sometimes the insurance company will mail you a copy, but you're likely to find out about it directly from the provider before you hear about it from the insurance company. Sometimes families also will continue to call and follow up themselves. So I have had families who have called in to the insurance company and been told, oh, you're approved, before I found out. So that's also fine. But if you're waiting on somebody to tell you, it's likely you're going to hear about it from your provider before you hear about it from your insurance company. The exception to that is if you have one of those patient advocates, a lot of times they will call you directly, and they may call you before they call the provider, or try to call you at the same time. If the provider doesn't immediately answer, they're going to call you and share the good news with you. So I always say, a lot of times I get to share with families that you are approved. The downside of that is that I also am the one who is often calling and saying, hey, we got a denial. Here's what we got to do next. So, the good and the bad come with that role. So, and so then once you're approved, you want to figure out next steps. So that might be that they need to get a single case agreement in place, or other contracting things. If you're from out of area, there may be a justification for why this needs to be provided in that, at that center. And so, especially if you're out of state or something like that. And then, just kind of understanding what those out-of-pocket costs look like, and, how you're going to cover that, whether that is, that you're just going to pay it, or, more than likely, you're going to be able to get some assistance from someone. And so just kind of thinking through that so that hopefully you're not getting stuck with a big bill at the end of the day. And just, try to be patient at the end of the day. I realize this process is frustrating for a lot of people. Everybody wants it to be like, hey, my kid has this disease, they need this therapy. Let's give the kid the therapy. But especially with the cost of these medications and everything, there's just a lot of T's that have to be crossed and I's dotted. On the other hand, like I say, a lot of times we have denials. And so, you know, there are ultimately next steps with a denial. And so it's important to understand why the treatment was denied, and then that should drive the next steps in terms of your process. And so usually when you get a denial, there will be an explanation for why it was denied. And so that should then drive your next steps. What I will say is on the first denial, never give up. There's still, there's lots of patients where I've gotten a denial on the first time, and then we have been able to reverse that in almost all cases. So the reason for denial, that if it doesn't meet the plan criteria, so this is the medical criteria. So here you really need to focus on filing an appeal, and that's going to be educating the insurer on why this patient ought to be able to get this drug, and so your healthcare provider will help with that. You can tailor the letter to that specific denial reason, and that's what I usually will do, is I really try to dive into that. Engage with other members of the team too. So that could be, yes, your physician, but also talk to your physical therapist, talk to others on the team who you work with, who may genetic counselors who may be able to give some insight or further inform that letter. And also just to give a second set of eyes to it. Ultimately, the more people you have who can do that, the better it's going to be in terms of providing a good letter. I've also seen misinterpretation of the policy, clinical data, or both. And so, for example, one of the things that we see with gene therapy is that you get your AAV antibody checked for most gene therapies that are approved. There's the way that it is displayed, if you do not understand how to read that lab report, can be confusing for people reviewing it. And so even though I look at that and I say, yeah, it's clear the kid meets the criteria, if it's your first time ever looking at one of those reports, you may not understand that. And so you could get a denial for that reason. I've also had complex medical policies where it says and or a lot throughout the policies. And if somebody misunderstood one of the ands, what should have been an or vice versa, that can lead to some confusion. So sometimes I've actually gotten these appealed very quickly by doing a peer-to-peer over the phone to say, hey, the kid meets the criteria, you just misapplied your own policy. That's my favorite denial because it's easy. But at the end of the day, that's not going to be a lot of them. And then there are other things here. Therapy may be deemed experimental or investigational. This is particularly true for patients who qualify for the therapy under accelerated approval. So with Elevidys, for those unfamiliar with accelerated approval, Elevidys was originally approved last year under accelerated approval for 4 and 5-year-olds. Then this year, in the last couple of months, we've seen that the label be approved with what we would call traditional approval or just normal approval for ambulatory patients, and it is now under accelerated approval for non-ambulatory patients. This gives a window for some insurers to deem accelerated approval therapies as experimental or investigational, and sometimes they call it E&I, experimental and investigational. And so they will deny it on that basis. I will say, in general, if this is the reason, they're not going to change their position because this actually falls into a plan exclusion or a way that the plan is built. But this can be overridden with what's called an external review. So in every state, you will have patients have rights under their insurance law that allow for an external review. So that means that an insurance company can't just willy-nilly deny everything. They have, if they deny something, a patient has the right to appeal to an external reviewer. And so that's going to usually be somebody who's somewhat familiar with the disease. It might be a pediatric neurologist, may not be a neuromuscular specialist. So this could be somebody who isn't super as familiar with the disease, but at least has some understanding and can interpret the information effectively. And they're able to then say, okay, this actually does meet standard of care. And so when I'm appealing to those folks, I'm really trying to make the point that this is standard of care. And so there's different ways to do that. We use consensus statements that have been made by different organizations or different groups of clinicians. We also, in some cases, I will take a whole bunch of other insurance policies that do approve the therapy for that patient and say, look, all these other insurers do. This is not experimental or investigational. This is actually standard of care, and others recognize that. So trying to figure out how you approach that's going to be a little bit different. But overall, the experimental and investigational denial is usually going to only be one on external review, which is usually the last step of appeal. Sometimes you can kind of just jump straight to it, but a lot of times you have to go through at least a couple other denials, which hopefully if you realize those are going to be denials, you just will navigate through that fairly quickly. The last type of thing is a benefit exclusion. This is an administrative denial, not a clinical denial. And ultimately, this cannot be overridden by just convincing them that your child needs this therapy. So usually when this is in a plan, you have, if you go to your insurance plan, there's what they call the plan documents or something like that. And it's a probably 100-page document that explains, we cover this, we don't cover that. Every plan has exclusions. So, just kind of the things that you might think of that might be excluded under a lot of insurance companies. Cosmetics, for example, will be excluded, cosmetic surgery or different types of things like that, cosmetic Botox, stuff like that. Or maybe massage therapy is often listed as an exclusion. There's a whole bunch of things. They'll have probably 50 things that are excluded. Well, sometimes in there, one of those line items is gene therapy. It's not going to say gene therapy for muscular dystrophy. It's not going to say gene therapy for Duchenne muscular dystrophy. It will say just gene therapy. So whether it's for hemophilia or for sickle cell or for Duchenne, they're going to not cover it. This is determined at an employer level. So these are always going to be ERISA employer-sponsored plans. Paul's going to talk a little bit more about that. But employers have a lot of latitude in terms of plan design, and so they're able to put these exclusions in. I will tell you that the person at the employer who made that decision probably didn't know what the decision they were making. Because if you don't live in the world that we live in, where this is a reality for patients, you think that gene therapy is some futuristic thing. It's all just clinical trials. It's coming in a decade. Most people don't realize that. So they just say, yeah, well, we're not going to cover that. And somebody probably tells them this might save you a few dollars a month per employee or something off of your insurance plan, because there's reinsurance plans and everything I'll talk about. But ultimately, it might save a small amount of money for them on average. And so they say, oh, okay, yeah, we'll do that. And it only becomes an issue when now I have an employee who actually needs this therapy and they can't get it because of this benefit exclusion. So I talk about this benefit exclusion as the one that then we have to think about, okay, what are we going to do next? And so at that point, you're going to want to talk to the employer, understand the benefit exclusion, and talk to HR. And so I'm going to just talking about this in general, this is going to depend on the company. I have had very large companies deny gene therapy, and in some of those cases, they can afford to just say, we're going to make an exception to this. I've also had really small companies who say, or just even mid-sized companies where they literally can't afford to do it. They don't have the money in the bank to pay for it. It's not really an option for them. They will often acknowledge, man, this was a mistake we made in designing our plan, but they're kind of handcuffed. And so a lot of times they feel bad, but it's like, we can't do anything. And so that's when you have to think about other options that I'll talk about here in a minute. But overall, this is going to depend a little bit on the patient and exactly what they're willing to do to try to overcome this and able to do. So navigating the appeals process, there are just multiple. I just want to go back to this is just the medical appeals Sorry, I'm kind of jumping around here a little bit, but the medical appeals, there's first level, second level, and then third level. So like that third level is that external. But basically each of these gets progressively more authority to overturn. So the first one is going to be this like internal one. They're mostly just like discussing the policy with you and making sure they interpreted the policy and the medical data correctly. The second level is really where they have the ability to deviate from the policy based on individual patient characteristics. The third is that external review that really has the ability to say, no, your policy is wrong, your medical policy is wrong, and we're going to overturn that and make you pay for it. So there's a few different levels there, just to be aware of. So I talked a little bit about this employer-sponsored plans that can have these benefit exclusions. And so I'm just going to talk a little bit about self-funded versus fully insured, because this doesn't apply to all employer-sponsored plans. Self-funded insurance is what is where this can actually happen. So in this situation, the employer basically pays a company, and these are often your national brand insurance companies, to run the insurance benefit. So for example, at Nationwide Children's Hospital, Aetna is what we call our third-party administrator, and they're the ones who run our health insurance plan. But we're a self-insured company here as well. And so the employer will then take on the risk associated with that. So basically, Aetna handles all of our insurance, and then they send a bill to the employer at the end of the month, and the employer then has to pay all those expenses. And then there's a little bit of a fee applied basically so that they make money. They're just kind of a middleman in this situation, and they enforce the policy that the employer decides to offer. And so in these situations, these employers will also often have stop loss insurance, and this is for extreme situations like gene therapy. So what employers want out of their insurance plan is they want it to be predictable. They want to be able to say, yes, on average, it's going to cost us this much per month for our employees to have insurance. We realize there's going to be some variation in that, but overall, we want to kind of smooth that out, and we don't want the big swings to, cause us financial challenges. And especially for smaller employers, they're going to want that threshold to be even lower. And so they use this stop loss insurance to mitigate those extreme situations. And on my next slide, I'll talk a little bit more about that. But the key is the self-funded plans have the flexibility to exclude anything really from their policy. The fully insured insurance, on the other hand, is where the employer, or this might be an exchange plan, for example, just pay a monthly premium to the insurance company. The insurance company takes on all the risk, and then they will pay out for the benefit that's provided. So in this situation, the insurance company is pooling these patients that are with this employer or through the exchange with all the other patients, and they're kind of collectively saying, okay, this is how much, this is what the risk is, and they're building all of that risk into their premium. And so ultimately, this will cost the employer a little bit more because for that risk, in exchange for that risk, the insurer is probably going to charge more. But on the other hand, the insurer takes on all the risk, so there's that benefit for the employer. So that's kind of the nuance there, and I bring this up because it's relevant to what Paul's going to talk about as it relates to ERISA, but also is where we see these denials for administrative reasons, that because the therapy is experimental and investigational, and these are some of the hardest denials to get around. And then just to explain a little bit about how this works from a stop loss standpoint. So most large employers are self-insured. They will have they use this to reduce the cost of health insurance for the employer. So they basically, like I say, they have lower expenses. The insurance company makes it probably less on average, but they also most of the risk is transferred to someone else, to the employer. And then this gives them more flexibility in benefit design because ERISA gives, which is the law for all of this, which applies to a whole variety of employee benefits. It gives them more flexibility on that. And so when there's a huge expense, there's a stop loss payment. And so the plan payment, which is basically the same as like your deductible on your insurance, is that the employer or whoever is sponsoring the plan has to pay a deductible amount. So that might be like $200,000. It might be $50,000. It might be $1 million. It just is going to depend on the employer and what their risk is that they have chosen to take on. But the point is that the stop loss takes on everything above that. And so really it limits that risk. And so that's why, why this becomes relevant is that this stop loss only applies when you follow your plan design. So when it says that gene therapy is excluded under your plan design, this stop loss goes out the window. And so suddenly the employer is on the hook for the entirety of the expense rather than just being on the hook for the 200,000 or 50,000 or whatever that is. And so I'm pointing this out just to kind of explain why your employer can't just say, oh, well, we'll just override it. It would be no different than if we had just included in up front, because it actually is different because they're going to take on a whole lot more expense. And like I say, if you work for a Fortune 100 company, maybe they can just do that. If you work for a small local company with 25 employees who, has $2 million in revenue for the year, they can't just write a check for for a gene therapy that costs millions of dollars. And so that's why this matters, because both can have employer-sponsored health insurance that are self-funded. Ultimately, if you get to a terminal denial, you can then consider options. You can't appeal to the employer. Ultimately, an employer can override everything if they're willing to write the check. A lot of employers aren't going to do that, especially if the insurance company says no, but they can do it. Are there other options for insurance? As much as I hate the idea that people are going to bounce around insurance companies in order to find the one that will cover their child, the reality is that most of us would do it to take care of our kid. And so sometimes that's going to be a secondary Medicaid. You can get secondary Medicaid to pay for it, even if it's not your primary insurance. There's processes around that, but you have to work through it. That may be getting another insurance plan. I've had people talk about switching jobs. There's different things here. I'm not saying that anyone is the right answer for you. You need to think about that for yourself. And then, are there other forms of advocacy? I've had people who, go, especially with government sponsored plans, go to local politicians and stuff like that. And then are there other therapy options? So that could be, is there a clinical trial open at our site that could take care of you? I realize I don't want to say that clinical trials are a substitute for commercial therapies, but at the end of the day, for some families, that might be the best way to get their child a therapy. Are there other therapies? Exon skipping, is that something that could be a bridge for them? There could be, there are other different things in the pipeline, and that could change over time here. I will say that I don't think that gene therapy is the best choice for everyone. There are other things that are probably in the pipeline or are even maybe approved that may be better for some patients. But nonetheless, just thinking about that and having that conversation with your provider is really important. And then, just understanding this process is going to take a while, especially if you get to this terminal denial. Anything you choose from here is going to take a long time. And so that's the unfortunate situation. I've had this process drag on for 1.5 years with a patient who had reached this point and had to do creative things in order to change. So, that's the challenge. And some of those things take a long time, and you don't have control over, moving it along. Sometimes you have control over some of it, depends. But I always say, let's talk about expectations. How long is this going to take? So you're gonna get your lab results. It can take a week. We can't do anything with insurance until we have lab results. Then we file the insurance, and the file with insurance. It's probably going to take up to 2 weeks for them to reply. So just kind of bake that in. We may then have appeals. That could take a month. It could take longer if we have multiple rounds of appeals that need to be done. Then we have contracting between the insurer and the hospital. I'd like to say this takes 2 weeks. I can tell you sometimes it takes 2 days. Sometimes it takes 2 months. This is a complicated thing. it should get smoother as time goes on. But nonetheless, there could be challenges here as well. It's going to take a couple weeks for the drug to ship. You should count on that. And then thinking about when you can get scheduled. So every step has a possibility for a further delay, but overall, you're really talking about a couple months in this process, likely from the time that you see your physician and they say, let's move forward with gene therapy until you actually are able to be dosed. And, I really, this is like something that it is, frustrating to families, is frustrating to providers. We all want to move these things forward faster, and a lot of times these things are just out of our control. And so, continuing to partner, I always tell families, you're welcome to keep checking in with me to see if I hear anything more. You're willing to advocate, definitely feel free to reach out yourself. I definitely have seen that help move things along as well. Once you're in the contracting phase, it's kind of hard to actually do that. But otherwise, there's definitely feel free to reach out. So with that, I'll hand it over to Paul before we do Q&A. Paul's got some great information about how this applies to public policy more broadly, because ultimately some of these barriers we want to get rid of for everyone and not just have to handle on a single patient basis. So I'll hand it over to Paul. Thanks.
Yeah, thanks so much, Michael. And actually, let me just share my screen here so everyone can see my slides. One moment, please. Okay, here we go. So really grateful to be joining everybody this afternoon or morning or evening, wherever you happen to be, to talk about specifically gene therapy access and public policy. Everything Michael has been going through this far has been talking about ways to access gene therapy on the ground. Truly, it's all the ways he and his team have found ways to access gene therapies for those that they serve. But really what I'm going to be doing is kind of zooming pretty far out from the on-the-ground work that Michael and his colleagues are doing, all the way to the work that we're doing in Washington, D.C. I'm in the MDA Public Policy Department, and really within our public policy and advocacy efforts, we try to change the public policies through legislation or through regulation or whatever happens to be that govern all the ways that these things work or oftentimes don't work, to try to make it better for everybody, not just for specific institutions, specific states, specific diseases, even for that matter, or folks with those diseases, but as much as we can, change it for everybody who's seeking to access gene therapies. So what I'm going to be going through today are our efforts to reform access to gene therapies through public policies, really across the four main insurance types. And you've already heard these terms used by Michael. But those four main types are Medicaid, commercial insurance, self-insured organizations, and Medicare. And I'm already going to have to give a disclaimer because whatever I'm going to be saying here is going to be inherently oversimplified and reductive, because within the time that I have, I can't get into the amount of nitty-gritty it takes to talk about the different kinds of self-insured organizations, or what is actually commercial insurance, or all those kinds of things. So naturally, for those of you who really know what you're talking about, you might point out a few things here or there of, well, that's a little oversimplified. Well, that's just going to have to be how it is today, just given the time that we have together. Okay, so I want to start with Medicaid, because Medicaid really is one of, if not the most important insurers for those seeking gene therapies. And the reason for why is that Medicaid is one of the most prominent insurers for children, as well as for those with disabilities. Medicaid is a state-run but federally influenced health coverage program for a number of individuals. Most people who know Medicaid actually think of it as a program for those of lower income. But while, of course, many folks with lower income will be on Medicaid, also many children and also pregnant women, people with disabilities. There are a whole different number of individuals who, whether they're actually low income or not, can qualify for Medicaid. Now, each state and territory runs its own Medicaid program. There's the saying that if you've seen one Medicaid program, well, you've seen one Medicaid program. And so Ohio Medicaid is very different than Colorado Medicaid, which is different than Texas Medicaid or Maine Medicaid. And now, all this being said, though, there are some baseline standards that the federal government sets that the state Medicaid agencies then have to comply with within their Medicaid programs. But from there can be a whole lot of differences across the different states. Now, one of the best things about the Medicaid program as it intersects with gene therapies is that there's a program called the Medicaid Drug Rebate Program. This is a law from several decades ago in which Medicaid agencies essentially struck a deal with the biopharmaceutical industry. And within this deal, the Medicaid agencies said that we will cover FDA-approved therapies if you, the biopharmaceutical industry, give us rebates, i.e. make the cost a lot lower. And so because of this deal that is struck and it's law and it's still in existence, Medicaid programs usually cover all FDA-approved therapies, and eventually they cover them to label. There can be some bumps in the road, and we'll get to that in a moment. But by and large, Medicaid is actually one of the best insurers, the best coverers for gene therapies or any pharmaceutical product for that matter because of this law. Now, this doesn't mean, though, that reforms aren't necessary, and there are a number of things that we at MDA are trying to do to make it easier to access gene therapies through Medicaid programs. So for one, the Center for Medicare and Medicaid Services, that's the federal government agency that oversees Medicare, which we'll get back to, but also oversees Medicaid. They're the ones who create those baseline standards. They're actually running a new pilot program in which they're pulling resources and expertise across different states so that instead of it's just one Medicaid agency trying to figure out how am I going to cover this new $3 million gene therapy, instead it's 10 or 15 Medicaid agencies that are all working together on how to cover these gene therapies, on what guidelines, what administration require, all the ways Medicaid agencies would have to otherwise do it alone. Now they're working together, working with the Federal Center for Medicare and Medicaid Services. And this is exciting because this can create more efficiencies, this can create quicker coverage, this can lower the amount of red tape and paperwork that's necessary. And right now they're actually starting this process with the gene therapy over in sickle cell disease, but we're expecting them to eventually come to neuromuscular diseases as well. Other reforms we're looking at include how drug utilization review boards operate. Drug utilization review boards are when an FDA-approved therapy actually is finally approved, then one of the first steps is for a Medicaid drug utilization review board to then look at it and say, okay, so how are we as a Medicaid agency going to actually cover this? Now, the problem is that oftentimes these are very opaque and behind closed door processes. And, sometimes conveniently, it takes 6 months, 9 months, a year and a half for Medicaid agencies to do this. That delay is problematic. So while they eventually will cover them and cover them to label, as I said, sometimes these drug utilization review boards can slow things down. And so that's why we're looking for ways to reform them. Also, while we're talking about the gene therapy and its cost itself, oftentimes the ancillary coverage, all the other things that need to be done for all the things leading up to an administration of a gene therapy, the potential other medical professionals that are present for the administration of the gene therapy itself. But then, as we know, for those of you who perhaps have gone through this journey or are exploring going through this journey, you may know that there's a whole host of 3 months of care at a minimum that then follows after the administration of a gene therapy. Many different visits to various different specialists coming back to the clinic, and that oftentimes may or may not be covered by Medicaid. So we're also looking for ways for Medicaid to be better covering not just the gene therapy itself, but everything that's necessary that goes around it. We're looking to increase genetic testing options within Medicaid. Some state agencies or state programs don't cover genetic tests that will confirm the diagnosis that could lead to a gene therapy. Oftentimes, if there's an individual in one state that needs to go to a specialist in another state, and we see this quite often in bordering states where the expertise, the best facility to go to happens to be across state lines. There's a whole host of different problems that can then arise. We're looking to streamline that process for individual to go from their home state to the state next door, or even further from that, for that matter, to get to their expert clinician. And then also looking for ways to streamline value-based purchasing agreements so that these very expensive gene therapies and the payments for them can actually be tied to the value that these therapies are bringing, not only to the individual, but also to society more broadly. So that's Medicaid. Moving over into commercial insurance, and this is again where I'm going to have to oversimplify. Commercial plans are private insurance plans. So now we're moving from public Medicaid to private commercial plans that are often offered through one's employer or sold through the Affordable Care Act marketplaces. And oftentimes for those of us who are working and get insurance through our employer, this is going to be the kind of plan that we are then offered. Or if we're not employed, or we're a student, or we just don't like the insurance that we're offered through an employer, we can go to the Affordable Care Act marketplaces and buy our own. Now, these commercial plans are actually also largely governed by state law. This is due to essentially the Constitution that leaves a lot of healthcare regulation to the states. But there are ways in which the federal government can get involved, and that's actually largely through provisions of the Affordable Care Act, which I've already mentioned a handful of times now. So outside of the state mandated benefits and then the federal essential health benefits, there's actually not a whole lot of requirements that commercial plans have to comply with, unlike Medicaid. And so by and large, commercial plans can cover what they want when they want. And that's why we see many, if not most of the denials for gene therapy actually happening in commercial plans, because there's no such requirement like the Medicaid agencies have to comply with compared to within commercial plans. And this is particularly true if therapies have been approved via accelerated approval, which Elevidys, as Michael's already mentioned, has been. So there are a lot of reforms that we need to actually make within this process. And there's several that are ongoing right now. So for one, we're working with a number of partners in other organizations, both within neuromuscular diseases as well as outside neuromuscular diseases, to limit the utilization management techniques that plans can use. And when I say that, I mean, what is utilization management? Those are step therapy. Those are prior authorization. Those are a number of ways in which insurance companies try to place hurdles in front of you, in front of your clinician, in front of your pharmacist, in trying to get you the therapy that is best for your experience. And so we're trying to actually reform the ways in which private insurance companies, commercial plans, can use these utilization management techniques to delay you getting the therapies that you would like. In addition, we're also looking at ways to increase coverage of gene therapies more specifically by amending the essential health benefits within the federal government's annual rulemaking. And to the right, on the bottom right of your screen, you see what the essential health benefits are. These are defined by the Affordable Care Act, but the federal government has a lot of latitude in how it then interprets what essential health benefits are. And each year, the federal government publishes what's called the Notice of Benefit and Payment Parameters, where they say, this is what essential health benefits for hospital stays mean, or this is what it means for laboratory tests, or this is what it means for preventative services. And so there's work that we put in to try to encourage the federal government to broaden those essential health benefits, which means that more things are going to be covered under commercial insurance. And then there's also ways we can actually change the law through Congress to also amend EHBs to try to include more within those protected benefits, if you will. And then finally, consideration of when there are blanket denials in commercial insurance. And we're going to see a lot of this right now due to Elevidys' label expansion in the non-ambulatory population of those with Duchenne. In fact, we've already seen a number of different plans, coverage plans, in which private insurers have said, yes, we're going to cover those with who are ambulatory with Duchenne, but we're not going to cover this therapy for those who are non-ambulatory. And there's actually exploration of whether that could be considered discriminatory under federal law, that individuals who have a more advanced disability are not able to get a therapy, whereas those who have a less advanced disability, at least at that time, are able to get that therapy. So that's another way in which we're looking at this challenge. But again, commercial plans are one of the hardest industries to reform, and they have very strong allies in Congress, and they do a whole lot of lobbying. So everything that we're doing here, we're facing some pretty substantial opposition to, but we're going to keep fighting nonetheless. Moving on from there to the other kind of private insurance that I wanted to mention, and Michael spent a good amount of time talking about self-insured plans or self-insured organizations. And these are organizations that are most often their employers that self-insure their employees. What this means is that the organization itself essentially acts as the insurer. And Michael went into fully insured versus self-insured, and there are differences, of course, there. And often who is actually administrating these plans is different. There can be a third-party contractor. Sometimes it's the HR department themselves if they're a small enough organization. But the thing to emphasize here is that self-insured plans or self-insured organizations, as Michael said, are governed entirely different than any of the other insurers that we're talking about today, because they are governed by the Employee Retirement Income Security Act of 1974. And you might be looking at that and thinking, well, what the heck does retirement security have to do with health insurance? Well, for the benefits that are offered by an employer that is self-insured, then whether it's healthcare or health insurance or not, by and large, it's going to fall under ERISA. And one of the quirks about ERISA is ERISA preemption, which means that state laws, and again, this is where I'm oversimplifying, state laws governing such plans are preempted by the federal law. So rather in comparison to Medicaid or private insurance, commercial insurance, I should say, where states have a lot of latitude to govern, this is an area where actually states do not have a lot of latitude to reform, and it's the federal government that needs to take the responsibility for amending ERISA. Now, this makes it one of the most difficult areas. I'm going to say this is the most difficult area to reform. So this means that it's up to Congress. And by and large, Congress hasn't shown much of an appetite to actually reform self-insured plans. And largely because of this, there are a whole lot of fewer protections for those who are self-insured or who are covered by self-insured plans than those who are covered by other forms of commercial insurance or by Medicaid or by Medicare. And so consequently, this doesn't mean that we're giving up, but it is going to be a tough road. Thankfully, the House Education and Workforce Committee, they're one of the committees up in the House of Representatives that have jurisdiction over ERISA, very recently actually put out a call for reforms, asking the community at large, how can we reform ERISA? And we suggested a number of things. We suggested that the House Education and Workforce Committee consider reaffirming fiduciary standards of employers and all contracted entities, and that includes pharmacy benefit managers. We've asked the House Education and Workforce Committee to look at how ERISA can better ensure coverage of specialty therapies under self-insured plans, and also addressing reinsurance carve-outs for gene therapies that Michael went into a little bit. Reinsurance or stop-loss coverage, those can be used largely interchangeably, again, oversimplified, but that's where an employer will buy insurance for themselves for their health insurance in case they have that $3 million gene therapy being sought by an employee or an employee's child. And if reinsurance is able to cover that, then that means the employer oftentimes is able to cover that. But oftentimes the reinsurance themselves will have carve-outs, and that kind of goes against the very point. And so we're looking at ways to reform that. But again, oftentimes the most effective advocacy within self-insured plans, within self-insured organizations, is not through public policy, and it's due to these complexities I've mentioned here. Instead, it's through that individual advocacy of talking with your employer, talking with an HR department, all the ways in which you could work with the Michaels of the world to try to get your employer to cover such a gene therapy. That's oftentimes going to be much more effective for self-insured plans than any amount of public policy could actually get to. So the final insurance I want to cover today is probably the one that's technically the least relevant, at least to where we sit right now for gene therapies, and that's Medicare. Now, Medicare is largely a federally run coverage program for individuals over 65, but also individuals who qualify for Medicare through qualification for Social Security Disability Insurance, or SSDI, and then also those with ALS and end-stage renal disease automatically qualify for Medicare as well. Now, Medicare, since by and large, the vast majority of individuals who are covered by Medicare are those who are over 65, the program is tailored for those who are over 65. And by and large, there aren't really any gene therapies available right now for those who are over 65, at least those that I'm aware of. But perhaps there could be in other areas that aren't neuromuscular, but looking at neuromuscular specifically, there is essentially no overlap between those seeking gene therapies today and those who are covered by Medicare. But that could change because there, as we know with Elevidys, there is now an approval for the non-ambulatory adult population of those with Duchenne. And so consequently, they could be covered by, they could qualify for Social Security Disability Insurance, meaning they could qualify for Medicare. And that could be a situation in which Medicare could be actually covering gene therapies. And if we see further gene therapy development within ALS, we might also see Medicare eventually covering gene therapies for ALS as well. And of course, we know many neuromuscular diseases have populations of individuals over 65, as well as populations who qualify for SSDI. And maybe a little ways down the road, Medicare will be covering gene therapies more frequently. But for now, really our focus within Medicare actually happened to go with some of the costs of care or opportunities for care that surround gene therapies oftentimes. And that's access to that genetic test in the first place. That's access to genetic counseling. Genetic counselors are not covered providers under the Medicare program, and we're trying to change that. That's also, just more broadly speaking, access to genetic medicine, access to geneticists, access to individuals who are PTs or speech therapists or dietitians that are oftentimes treating those with genetic conditions. Access to these specialists are often lessened within Medicare because Medicare is not used to having to cover these services. So we're looking to try to reform that as well. Medicare Part B, as in boy, is where eventually gene therapies will likely be covered more frequently because they're administered within a inpatient facility by and large, though I know that also could be changing going forward. So there are efforts to restructure Medicare Part B. So we're going to be looking at those efforts through the lens of gene therapy access. And as I mentioned with multidisciplinary care coverage, and we're starting with an ALS, but we're trying to get better coverage of multidisciplinary care, which I know for those of you who are joining us from our community, you know multidisciplinary care is the model for obtaining care. But Medicare isn't very good at covering multidisciplinary care. They might cover the clinician, they might cover the registered nurse or the physician's assistant, but they might not cover anything else. And so that's going to become very relevant in the context of gene therapy when everybody else is going to be necessary within care. So I think that is actually where I'm going to finish up today. I will pause and ask Marissa if you'd like to be for us to be taking questions at this point.
Yes, thank you so much, Dr. Storey and Paul, for being here today and for all the excellent information walking us through all that. We do have some questions, so let me pull those up here. There were a couple questions about individuals living outside the U.S. and having access to the infusion. So do you know of any cases where a non-U.S. citizen living outside the U.S. Had access to gene therapy, or if a foreign family has a possibility to move to the U.S., how that might work at all?
I think the key here is that the patient has to become eligible for U.S. insurance. And so there's different ways that would have to happen. That would have to be under certain types of visas and everything. I think you have to talk to an immigration attorney probably to really get the best insight into how that works for your individual case. Certainly, there's chatter about families raising the funds to come and do this in the United States. But if you're really talking about insurance specifically, that's going to be dependent on your ability to, come to the United States on a permanent or semi-permanent basis to obtain, insurance like people who live in the United States have. Obviously, insurance companies are looking at this and saying, we don't want people to come get on a plan for a brief period of time and then leave. That's obviously not a viable thing for the insurance company to have that happen at any scale. And so there are rules around what makes you eligible to get insurance or not get insurance. And so that's going to, depend on your individual situation. I am not an attorney, certainly not an immigration attorney, so I cannot speak to, the exact details of that, but that's going to depend on your individual situation.
Thank you. Probably another question for you, Dr. Storey. Can you please speak about specialty pharmacy and how that works? Does the insurance company determine the specialty pharmacy?
Yeah, so for gene therapy, some hospitals will use a specialty pharmacy for gene therapy. So there's what we call buy and bill, and then there is specialty pharmacy, or sometimes people call it white bagging or things like that. There's different terms for it. But basically, the question is does the hospital do all of the contracting and then the submission of the taking on the, they actually buy the drug and then bill the insurance for it and get paid? Or do they use an outside specialty pharmacy who then will basically take on that risk, and also they will get paid as well. That's going to vary by site. I can say, we do all buy and bill. We don't use specialty pharmacies here for those therapies, but there are sites that do. And there's pros and cons to that. It's going to be a site specific decision. Some of the specialty pharmacies, depending on the therapy, some of them will be directed by the insurance company, like this is the one that we use. Some will be open, and the site might say, well, this is the one we prefer to work with. There's going to be different things. I will tell you that for you as a patient, there's not a lot of value that the specialty pharmacy is going to add to the equation. They're part of the process, basically, is that they handle the financial risk, and then the product does physically have to go to them because they are technically a pharmacy, so they have to dispense it. So on the way to the hospital, they will make a stop at that specialty pharmacy. In general, they will open the shipping container, put a sticker on it, and to say, basically a prescription label like you would have on any prescription. They'll put it on there, and then they'll refill the dry ice and send it on its way. So it's a very limited function. They're not actually drawing it up like we do at the hospital or administering it, obviously. But it's really a question that the hospital is going to make a decision around their willingness to take on the risk of that. Some insurers may try to push it through the specialty pharmacy route or through the buy and bill route. That may be a preference that they may discuss. But in most cases, hospitals have this is the way that we do it here at our organization.
Gotcha. Makes sense. All right. Question for you, Paul. People obviously get excited and energized by what you're talking about. How can they get involved or make their voice heard in some of these issues?
Yeah, absolutely. Well, great question, and I appreciate the desire to join us. Absolutely, because there's a whole lot we're doing in this area, and the best way is just to join our advocacy network. Frankly, you can go to mda.org/advocacy to join. And the way to contact us is advocacy@mdausa.org. But by joining, you're going to get monthly updates of all the work that we're doing, both within gene therapies, but everything else we're doing for those with disabilities, when we've really been focusing on the gene therapy access side of things, we're doing a whole lot on the gene therapy development side of things as well, including trying to reauthorize the Rare Pediatric Disease Priority Review Voucher program, which is a big incentive for the development of gene therapies in the first place. So I would say please join us, because you're going to have a whole lot of opportunities to be sending letters to your congresspersons. You're going to have opportunities to be sharing your story on a number of these things. It's going to be a busy rest of the year and the next year for that matter as well. So anyone who can join us, please do. We're gonna keep you busy, that's for sure.
Great, and we'll put that link in the chat too. We had a question come in about if either of you have experience or could speak about coverage with Veterans Administration Health or the VA.
So I don't have any experience with doing any gene therapies for VA. I mean, at this point, most patients who the VA is unlikely to be the payer for a lot of these therapies. But certainly, as more therapies become available and you have, later onset diseases and things like that, that's certainly a possibility. The VA is often a closed network system, so they may choose to provide this within their own network, or they may choose to outsource it to another organization. That's just going to depend on the situation. Certainly, I think about and that may depend on your region too, because in some cases there's more services in some parts of the country that will be done by the VA, where others they will say either you need to go to this other part of the country to get services, or we will allow those services to be provided at a local non-VA provider. So it's just going to depend on your situation and the disease. I don't have I don't have any experience specifically with gene therapy with the VA. So I don't know if you have anything to add to that, Paul.
Not much. There may be veterans who, through coverage for their families, is potential that children could be with Duchenne, or children with SMA could be seeking therapies through that process. But admittedly, that's not something I've become familiar with either. I chose the 4 insurance types for a reason, as those are by and large the only 4 insurance types we see covering gene therapies. But Rebecca, for your question, we would certainly be happy to look into it further, or reach out to us. If you're having experience with the VA trying to obtain a gene therapy, tell us about it, because that's an area we might want to be more active in. And that's, again, where emailing us at advocacy@mdausa.org could be really valuable.
I can speak to TRICARE, so that's for active duty military and their families. We have seen coverage from TRICARE for multiple different gene therapies. It's certainly they have different structures. They're going to operate very much like Medicare in general, and so we've seen that approved on a patient-specific basis for both Elevidys and for Zolgensma. So, yep.
Time for just one more question. And again, sorry if we don't get to every question. We will try to circle back with you. But wanted to ask if you have experience with insurance approving both gene therapies such as Elevidys and exon skipping at the same time.
Yeah. So for those unfamiliar with exon skipping therapy is available to about 20 to 25%. I don't know, Dr. Byrne may correct me on that, but of the Duchenne population. It's a therapy that it depends on your genetic mutation. You have to have certain deletions adjacent to. So we would usually talk about exon 51, exon 53, exon 45 amenable skipping. And so these therapies basically produce mostly complete dystrophin. So with Elevidys and some of the other products in clinical trials, they're producing shorter forms of dystrophin. It produces a mostly full dystrophin product. So these are approved for, like I say, a limited percentage of the population. In most cases, insurance companies are asking or requiring that these therapies be stopped when Elevidys is initiated or given. There's not clinical data, to my knowledge, showing additive benefit of these therapies. Obviously, in both cases, you're basically producing functional dystrophin, and so it would be additive, if anything, would be kind of the way that somebody might expect that to work. But I think that it's definitely a bit of a hard sell to an insurance company. These therapies are also incredibly expensive, can cost over $1 million a year in some cases for older patients, and in the absence of data, that's going to be very difficult. I think that the question really is going to come down to, why is this specific patient likely to benefit from exon skipping therapy? And so I will say that if you, for example, received Elevidys and then a year later you don't really seem to be benefiting, and your physician did a muscle biopsy and found that you're not actually expressing any microdystrophin, I could see a really good case for that. If you think that you're really benefiting from gene therapy, in that situation, you're probably not going to do a muscle biopsy just to find out. But if you did, you'd probably find out that you're expressing 40 or 45% dystrophin, maybe, or something like that. It's going to be a lot harder to say that by adding exon skipping therapy on, you're going to actually get a benefit, because in general, exon skipping therapy adds maybe 5% dystrophin, and I don't know that additive benefit is likely going to be correlated with clinical benefit, or at least it's going to be really hard to convince an insurance company of that. So I think these are things that we need clinical trials on, but they're also difficult clinical trials to do. The exon skipping clinical trials have been hard to do in general, because you're talking about a fairly slow progressing disease, a limited patient population. Like I say, not every kid with Duchenne is eligible for these therapies. And so when you start talking about, clinical trials with, if we add this therapy and this therapy and this therapy, you start to get into a really messy, clinical trial situation. And then you're saying, well, what does benefit look like? It's a challenging question. And so I think you're going to see difficulty with getting that covered. But there probably are patient-specific situations where it may make sense to talk about that with your physician.
Makes sense. All right. Well, I want to thank you both again for being here. We appreciate your preparation and just spending the time and sharing your expertise with us. So thank you so much. I'm going to, just for the sake of time, we're going to kind of move forward with our next presentation. And just quickly, we do have this new insurance guide that Dr. Storey brought up on the screen, and we put a link in the chat. We'll do that again, but feel free to download this and use it as needed and as it's helpful. And again, we also encourage you to become an advocate and to work with our public policy and advocacy team with Paul and share your voice.